Okay. Hey, I'm Mike. I'm going to be your nurse practitioner student today, doing a head-to-toe physical exam on you with your permission. Is that okay?
Yeah,
All right. I'm going to get a little hand hygiene. And when I'm doing that, will you tell me your name?
sure, Danny.
Danny? Okay. And Danny, do you know what year it is?
2024.
And how old are you?
36.
All right, Danny. So to start this, we're going to start with our 12 cranial nerves. We're going to start with the first cranial nerve. The first cranial nerve is the olfactory. It is a sensory nerve. So I'm going to have you test the patency of your nose. Go ahead and occlude one nostril for me and take a nice big sniff in. And do it on the other side as well. Perfect. Go ahead and close your eyes for me. And we're going to cover one nostril. I'm going to see if you can tell the smell, okay? Go ahead and smell in.
Vanilla.
Yeah, that's very good. And we're going to do the same thing with the next nostril. Go ahead and occlude it. And what smells this?
Mint.
Yep. Perfect. So her first cranial nerve, the olfactory nerve, is intact. She was able to smell both of those sensations. So moving on to cranial nerve number 2, and that's the optic nerve. It is a sensory nerve. We're going to first check her visual acuity with a Snellen chart, which we're going to have to hold 6 feet away. So I'm just going to get right here. Are you able to read? What's the lowest line you can read for me?
The last one. LEFODPCT.
Perfect. And I'm going to give you this piece of paper here. You can cover one eye for me. And you go ahead and see what the lowest line you can read.
Same one. LEFODPCT.
Perfect. And then with both eyes?
LEFODPCT.
Perfect. So her visual acuity is intact. She was able to read the Snellen chart appropriately. Next, we're going to move on to the visual fields with the confrontation exam. So I'm going to give you this paper, and I want you to hold it over one eye, and then I'm going to make either a 2 or a 1 on each of your visual fields, and I want you to tell me what you see, okay?
Okay. 2. 1. 2. 1. 2. 1.
Perfect. And go ahead and cover the next eye. We're going to do the same thing.
2. 1. 2. 1. 2. 1.
Perfect. So her confrontation test was passed. She has full visual fields, able to see and all that. Next, we're going to switch to the fundoscopic exam. Let me get my fundoscope here. Perfect. Those settings should work. Okay, so I'm gonna have you go ahead and take your glasses off for me, just so I can test. Here, I'll steal them for you, and I can give them back to you if you need. So I'm gonna be looking right at your right eye. So it's my right eye against your right eye. I'm gonna get a little bit close to your head. Okay, so go ahead and turn towards me and just kind of look right at my nose for me. Sorry, it's gonna be a bright light. Okay. All right, so her red reflex is intact. I'm going to move in a little closer, okay? All right. All right, perfect. So her optic disc is intact. It's pink, it's creamy, round and clear. The retinal background is red and orange. And her there's no cupping. The veins to the arteries are at a 2 to 3 ratio. And I'm going to do the exact same exam on her other eye. We're going to do left to left. Um, Sorry, it might take me another second because I'm not left-handed. So I'm going to start off looking for the red reflex far away. Okay, perfect. Now I'm going to move in a little closer. Sorry. Perfect. Sorry about that bright light. So her optic disc is pink and creamy, round and clear on that left eye, with the retinal background being red, orangish in color. No increased cupping. The veins to artery ratios are about a 2 to 3 ratio. So moving on to the next cranial nerve, which is cranial nerve number 3, and we test cranial nerve number 3, 4, and 6 together, which is the ocular motor, the trochlear, and the abducens, and they are for their motor neurons, and they motor give you eye movement. So the first test that we're going to be doing is our Perla test, checking to see how our eyes move for light. So I'm going to have you stare right at my nose. First, I'm going to shine a light in your eyes, checking for a direct pupil constriction. And then I'm going to shine a light in the same eye, checking for consensual pupil constriction. Okay? Perfect. Go ahead and look right at me. Perfect. Direct pupillary constriction is intact. Look right at me. And consensual pupillary constriction is intact. We're going to check now the right eye. Direct pupillary constriction is intact. And we're going to check that left eye. Perfect. That left pupillary constriction, or consensual pupillary constriction, is intact. Next, we're going to move on to the I have to check my notes there. The accommodation test. So I'm going to have you stare at the wall behind me, and then I want you to switch your gaze to my finger right in front of you, okay? Now go ahead and switch. Perfect. Stare at the wall again. Hold it there. Go ahead and stare at the wall one more time. And back at my finger. Perfect. So you can see a narrowing of the gaze. The pupils accommodated perfectly for the close proximity of the finger, so her accommodation is intact. So the patient's perla is all intact. Next, we're going to move on to do the corneal light reflex. Give me a second. Let me grab that. All right, so next we're going to check the corneal light reflex, where I'm going to shine this pen light at the bridge of your nose, checking to see that both eyes react equally. Go ahead and look right at me. Perfect. And there's an equal reaction bilaterally, so the corneal light reflex is intact. Next, we're going to do the cover-uncover test. So I'm going to have you, or actually, I'm going to do it for you. So I'm just going to uncover and cover one of your eyes. Perfect. Perfect. So no eye twitching, no nystagmus, no any abnormalities on that one. So she does have a positive or a negative cover-uncover test, which means her cranial nerves are intact. We're going to do the fields of vision real quick. We're going to test them in a L shape, so go ahead, or an H shape, excuse me. Go ahead and stare at my finger, and only tracking my finger with your eyes. Go ahead and follow it for me. Perfect. 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 All fields of vision are intact, and she has complete fields of vision. Next, we're going to move on to the trigeminal nerve, the cranial nerve number 5. Now, cranial nerve number 5 is a mixed cranial nerve. So it is a sensory and motor nerve. To test that, we're first going to test the sensation of the face, the eyebrows, and the cheeks. So I have something sharp and something nice and dull for you. This is going to be your dull sensation, and this will be your sharp sensation. So go ahead and close your eyes for me and tell me which one you feel, okay?
Dull.
Perfect.
Sharp.
Perfect.
Sharp.
Perfect.
Dull. Sharp. Dull.
Perfect. You can go ahead and open your eyes again. So the sensation of the face in the eyebrows, cheeks, and chin using the cotton ball and sharp object are intact. So next we're going to check the, that was checking the sensorial part of the trigeminal nerve. Next we're going to check the motor part of the nerve. Go ahead and clench down for me nice and hard. Perfect. Good strong master muscles. Go ahead and shift your jaw side to side for me. Perfect. She had nice straw mastication right there, indicating that her motor are intact. She had good lateral jaw movement, which means that her motor portion of the trigeminal nerve is intact. Next, we're going to move on to cranial nerve number 7, which is the facial nerve. The facial nerve is a mixed nerve. Sorry. So to test the sensorial part, it innervates the anterior 2/3 of the tongue, and to test that, you would just test taste on that, but we're going to defer that for this video. And then the motor part of that nerve is the movement of the forehead and mouth. So I'm just going to have you kind of raise your eyebrows for me, make a big smile, puff out your cheeks. Perfect. So she was able to do all those motor controls without any difficulties. So the motor portion of the facial nerve, or excuse me, yes, the facial nerve is intact. So moving on, cranial nerve number 7 is the acoustic nerve, and that is going to be the Weber and Rhines test, and it is a sensory nerve which tests the hearing. The point of the Weber and Rhines test is to make sure that the air conduction is twice as long as the bone conduction. So I'm going to strike this, goodness, I forgot what it's called, tuning fork on the desk, and I'm going to put it at the very top of your head, and I want you to tell me if you're unable to hear the vibration or sensation on one of the ears, okay? All right. You able to have that both equally?
It's equal on both sides, yeah.
Equal on both sides? Perfect. If it was not equal on both sides, if it was lateralized to one side or another, that would either indicate sensorial hearing loss or conductive hearing loss. So next test is the Rhines test. So I'm going to strike the tuning fork again. I'm going to put it on the mastoid bone behind your ear. And after that, I'm going to put it right in front of your ear to check the air conduction. The mastoid bone will be checking the bone conduction. We would time this to make sure that the air conduction was lasting twice as long as the bone conduction, but for sake of the video, we're just going to demonstrate it and not time it. Okay? And I would wait until she was unable to hear it anymore, and then I'd put it right in front of her ear and let that time out until she couldn't hear the vibrations anymore. And that was the Rhines test. So the patient's 8th cranial nerve is all intact. Cranial nerve number 9, cranial nerve number 10 are tested together, the glossal pharyngeal and the vagus. The glossal pharyngeal, or they're mixed nerves, meaning sensory and motor. So to test the sensory part of it would be the posterior 1/3 of the tongue for taste, and you just have them taste something on that. But we're going to defer that for as well. But to test the motor portion of those mixed nerves, we're going to do a swallow test. So go ahead and swallow for me. Perfect. Swallowing is intact, so that part of the motor nerve is intact. And go ahead and get my pen light so I can see inside. Go ahead. Go ahead and open your mouth and say, ah. Perfect, uvula is intact. And then I'm going to have you do that one more time and check your gag reflex, okay? Perfect, sorry about that. I know it's a little uncomfortable, I apologize. Moving on, the next cranial nerve is nerve number 11, and that is the accessory nerve, and that is a motor neuron, and it innervates the trapezius muscles and the shoulder muscles. So I'm going to have you go ahead and raise your shoulders against my resistance. Perfect. I'm going to go ahead and have you push your cheek, turn your head towards the opposite side. Perfect. We're going to do the same on that side. Perfect. She was able to move her head against resistance and shrug her shoulders against resistance, meaning that her accessory nerve is intact. I'm also going to have you push your tongue on the side of your cheek. Perfect. And then do it this side. Perfect. So she was having no problems with any of those motor functions, meaning her accessory nerve is intact. Moving on is our 12th and final cranial nerve, which is the hypoglossal nerve, and that is a motor neuron, and that is innervates for tongue movement. So for that, we're going to have you go ahead and say the words light, tight, and dynamite.
Light, tight, and dynamite.
Perfect. And then I'm going to have you stick out your tongue, wiggle it, and then push it in your cheeks one more time. Perfect. Perfect. She was able to do all that no problem, indicating that her 12th cranial nerve is intact, the hypoglossal. And after that, we're going to move on now to our head assessment. All right, so moving on to the head and face. Patient sitting here appears generally well, not in distress, age appropriate, appropriate for her race and ethnicity. So what first we're going to do is inspect and palpate the head. So looking at the head, there's no signs of any alopecia. Her scalp and skull look normal cephalic right now. Looks like the hair is evenly distributed. Are you okay if I touch you?
Yep.
Perfect. There's no lesions, no tenderness. I'm going to go ahead and press on your frontal sinuses. Does that hurt at all?
Nope.
And the maxillary sinuses, that hurt?
No.
Okay. Frontal and maxillary sinuses are clear and do not have any tenderness. So we're going to move on to the facial features are symmetric, smooth, skin is pink, warm, and dry. Yeah. So moving on to the eyes. First, we're going to don't do that yet. So I'm going to inspect it. The eyes look no abnormalities. They look really even. No ptosis noted. No draining crusties. No discharge. The corneas look clear without opacities, and the irises are flat on bilateral eyes. So we're going to move on to the ears. First, we're going to inspect the outside of the ears, checking the outside, looking at the external auricle. No drainage, no lesions, no crusties or anything like that. Are you okay if I examine the inside of your ears?
Sure.
Perfect. I'll hold the stethoscope with the 3 fingers, or not the stethoscope, the otoscope with the 3 fingers on it with my pinky. It's going to rest on her cheek. First, I'm going to do an upward and outward tug just to see if you have any tenderness. Any tenderness there?
Nope.
And then any tenderness there?
No.
Perfect. All right, so I'm going to insert the probe tip. Slightly. Any pain?
Nope.
Perfect. The right ear, the tympanic membrane is pearly gray. There are no bulges, no fluids. The handle and the short process of the malleolus are visible. Yeah. So now I'm going to look at the left ear with my left hand. Apologies. Perfect. Again, her tympanic membrane is intact. It's pearly gray. There are no bulges, no fluids. The handle and short process of the malleolus is visible and intact. Put this down. And the right cone for the right ear, the cone of light is about 5 o'clock, and for the left ear, it was about in the 7 o'clock position. And she had a negative tug test, no painful, no tenderness, and no signs of otitis externa. Yeah, so all right, and the outer ears are in line with the canthus of the eyes. So next we're going to inspect the nose. So I'm going to insert the otoscope speculum slightly in and take a look and see what I see. Are you okay with that? Yep. Perfect. 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 So the mucosal membrane is pink. There's no lesions. Their turbinates are visible for the inferior and the middle, and the superior cannot be visualized. The patient does not have any septal deviation. Next, we're going to move on to our throat and mouth inspection. So I'm going to grab the pen light. Go ahead and say ah for me. Actually, let me get a tongue depressor as well. Sorry about that. I was ill prepared. Let's try that again. Perfect. Mucous membranes are moist. Go ahead and lift up for me. Perfect. All right. Go ahead and close. Mucous membranes are moist, gums pink, no bleeding, dentition is good, teeth are aligned, hygiene is well off, roof of the mouth and tongue is moist and pink with no fissures, white patches, lesions. The tonsils are about a 1 plus, and tonsils are graded on a scale from 1 to 4, with each number indicating an increase in about 25% of the space they take up to touching. And now I would classify her Millipati score if the patient needed to be intubated. The Millipati is graded from a grade of 1 to 4, with 1 being able to visualize the full soft palate and the uvula, and 4 means only the hard palate is visible. This patient has a Millipati score of 1. So next we're going to move on to the neck. We're going to inspect the neck and trachea. So neck is, the skin is intact, no lesions, no crusties. The trachea, sorry, I'm just going to touch you and feel. Trachea is midline with no deviation to either side. Yeah, so now I'm going to try to palpate her thyroid. So moving around to check the patient's thyroid. Just going to place 2 fingers right under her cricoid cartilage. I'm going to feel to either side, looking for any nodules or masses. Go ahead and give me a swallow. Perfect. I'm going to have you tilt your head to the left. Go ahead and turn left and slightly down. I'm going to displace the left thyroid laterally, again feeling for any nodules or masses, which the patient is free of. I'm going to have you go ahead and tilt your head to the right and tilt slightly down. I'm going to go ahead and displace the right thyroid, feeling for any nodules or masses, which there are none. Perfect. So next I'm going to palpate for lymph nodes. Let me come back around. I'm going to palpate for lymph nodes. Lymph nodes should be small, movable. There should be about 1 centimeter in size, movable, and very regular. So the first we're going to check is the preauricular lymph nodes right in front of the ears. And then the next we're going to check the retroauricular auricle. Perfect. Next we're going to be checking the occipital lymph nodes right in the back, right here. Next we're going to move on to the 3 sets of lymph nodes that are under the chin. The first set is the submandibular, the first set is the cervical lymph nodes, and then the submandibular, and then the submental lymph nodes, going in that order. All lymph nodes are less than 1 millimeter, and they're movable, and they are very irregular, very regular. Next, moving down the neck, we're checking the deep cervical lymph nodes on the sternocleidomastoid muscle. So following the neck track down, they're a little deeper, so you have to palpate a little more, and those are normal. Next, we're going to check the lymph nodes that are on the posterior triangle of the neck. Perfect. And then we're going to check the subclavicular lymph nodes and the infraclavicular lymph nodes on both sides. Perfect. All lymph nodes were regular in shape. They were less than 1 centimeter, and they were all movable and mobile, and they were really soft. So moving on, we're going to now move on to the posterior thorax for the patient. So I'm going to have the patient turn around for us. All right, we have the patient turn around with their posterior facing the camera. For this exam, we would dress the patient or get the patient undressed and have them into a gown so we could visualize the entire posterior. But for this video demonstration, we're going to have our patient keep her shirt on. When we're inspecting the posterior thorax, we want to inspect for size, shape, any lesions, scars, make sure everything is symmetrical, there's no masses or any other structural abnormalities. We want to make sure that the lateral diameter is less than the AP diameter, no barrel chesting. So yeah, first thing that we're going to do is we would inspect for the symmetry, the color. So patient has good color. There are no scars, no lesions, no nevus, no masses. Skin is pink, dry, intact, and the AP diameter ratio is about a 1 to 2. Patient is very relaxed and comfortable in breathing at a normal rate. So next I'm going to palpate. So I'm going to start bilaterally with my the palms of my hand, my plantar surfaces, and then I'm going to go down and palpate her back. Are there any pain or tenderness?
No.
What about here?
No.
And here?
No.
And here?
No.
What about here? Here?
No.
Here?
No.
Here?
No.
Perfect. So the patient doesn't have to have any pain or tenderness along the spinous processes or down the entirety of her posterior thorax. Now I'm going to see if her breathing is symmetrical by finding the T10. So I'm going to look for the inferior aspect of the scapular wing, and I'm going to find that right here, and I'm going to move over and then down about 2 vertebrae, and leaving my hands in place. I'm going to have you take a nice big deep breath for me. And out. And I'll have you do one more. Perfect. The patient has bilateral expansion that is symmetrical. So next I'm going to move on to the tactile perimetus. I'm going to have you say 99 every time you feel me touch your back, okay? Okay, thank you. I'm going to palpate with the bony surface of my palm, not letting any other part of my hand touch the back because it could absorb some of the vibration that the whole test is assessing for. So go ahead and say 99 for me.
99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99.
Perfect. The vibrations are clear, strong. I'm not feeling any dullness or fluid noted that would be indicative of consolidation or pneumonia in the lungs. So next we're going to move on to percussion. We're going to percuss in all fields. How you percuss is that you take your third digit of your non-dominant hand and only rest that on their back, and then you can tap with the second and third digit of your dominant hand in each lung field. You're looking for resonance should be hollow and clear. Any dullness is a sign of consolidation. Any hyperresonance could be air filled, as you'd get with emphysema or COPD, or possibly hitting a flat bung. So we're going to percuss now. Any pain when I was doing any of that?
Nope.
Perfect. So the percussion is clear. She had normal resonance all throughout her lung fields. No dull or hyper resonance sounds. So it's indicating that she has normal, healthy lungs and no consolidation masses or hyperinflation as seen with emphysema or COPD. And then so next we're going to assess for the costovertebral angle tenderness, the CVA tenderness. So we're going to find our CVA angle, which we find our 12th lower rib. And we're going to put our hand right over it and give it just a gentle tap. Any pain right there?
No.
Perfect. I'm going to find our 12th rib. Any pain?
No.
Perfect. So she has no CVS tenderness noted, which is over the kidneys, which would indicate a type of kidney infection or possibly kidney stones or anything like that. Moving on, we're going to move on to auscultation of the back. And I'm going to clean my stethoscope right in front of the patient so they know that it's being cleaned and that it is a clean stethoscope. With auscultation, we are going to listen in all lung fields. We're going to be listening for an entire respiratory cycle. The bronchial breaths are located in the upper part of the respiratory field, but you're not going to hear them in the posterior. So anytime I put my stethoscope on you, I want you to take a nice big deep breath, okay? And you can stop if you start getting lightheaded or dizzy, okay? Big deep breath. Perfect. Deep breath. Perfect. And all lung fields were clear. There were no adventitious breath sounds like wheezing, rhonchi, rales. Just so the next test we're going to test for is the oh goodness, I can't remember how it's spelled. Egophony. And every time you hear the stethoscope get placed on your black, I want you to say EE for me, okay? Okay. Go ahead.
EE. 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 E.
Perfect. So I was only able to hear the muffled E sound. which would change to an A sound if there were any fluid or consolidation in the lungs. Um, Going back to what normal lung fields should sound like, the bronchiovesicular lung sounds are heard in the mid-scapulary areas. The vesicular lung sounds are heard more in the lung periphery. Um, and the adventitious breath sounds or your abnormalities, your wheezing, your rhonchi, your rales, and things like that. Um, okay, so moving on, we're going to move on to the anterior part of the chest now. So you can go ahead and turn around for me when you're ready. All right, we're going to now assess our posterior thorax, or the posterior chest. No, excuse me, anterior. Now the patient is facing us. Anterior portion of the chest. So starting out, we're going to inspect for shape, symmetry, any lesions, scars, masses, nevi, or any structural abnormalities. Looking for any pectus excavatum or anything like that, which the patient has normal skin color for their ethnicity. The skin's pink, warm, dry, and intact. She's not pale, cool, or diaphoretic. So the next thing that we're going to do is assess for her respiratory rate and rhythm. The patient is breathing normally around 16 to 17 times a minute. She's not in any distress, not using any accessory muscles. So for the next test, we're going to auscultate for her lung sounds. Again, the bronchiovesicular breath sounds are heard over the bronchi. The vesicular breath sounds are heard over the peripheral lung tissue, and the bronchial breath sounds are heard higher up in the upper part of the chest over the trachea, which can only be heard anteriorly and not posteriorly. The patient has clear lungs, no adventitious breath sounds, which would include rhonchi, wheezes, rales, crackles. Yeah, and that will conclude the portion for the anterior chest, and we're going to move on to the vascular system. So first, we're going to note a couple of different landmarks here. What we're talking about our cardiovascular system. So the um, uh, aortic, uh, goodness, drawing a blank. So you listen for the aortic sounds at the second intercostal space, right mid-clavicular line. You'll be listening to the pulmonic space on the second intercostal space, mid-clavicular left side. Um, Going down, you're going to hit the third intercostal space, which would be Erb's point. The fourth intercostal space is the best to listen for the tricuspid valve, and the fifth intercostal space, mid-clavicular line, is where you listen for the mitral area. S1 and S3 and S4 can be heard at the mitral valve area when the patient is in the lateral decubitus area. S2 is best heard in the aortic area, and a split S2 is best heard in the pulmonic area. So moving forward with that, let me grab my stethoscope. Perfect. I got my stethoscope now with me. And so in the mitral valve area, you would listen best for a, excuse me, over here, you'd listen best for a mitral valve prolapse. There are two different tests that you can do. We're not going to demonstrate them now. We can just talk about them. Which the first one is the squat test, and the second one is the Valsalva maneuver. So for the squat test, you listen over the mitral area with the patient standing, and as they squat, if a clicking goes away or is diminished, there might be a mitral valve prolapse. If the clicking sound is accentuated or louder, it could be from aortic stenosis. Again, if the clicking gets louder, it's from the aortic stenosis or probable aortic stenosis. And if the sound goes away during the squat test, then it is a probable mitral valve prolapse. For the Valsalva maneuver, the patient lays flat. We're listening over the mitral area. Um, and then we ask, with one hand on the patient's abdomen, we ask them to bear down. Um, if they bear down and the sound becomes louder while they are straining, it is a probable mitral valve prolapse. If it diminishes or gets quieter, then it is a probable aortic stenosis. So I'm going to have you go ahead and lay down for me. So the first thing that we're going to do is inspect the chest, make sure there are no abnormalities, no lifts, no heaves. You can't see any pulsatile movements that shouldn't be there or anything like that. And after you have inspected, the next thing you're going to want to do is palpate. So we're going to palpate in all 5 of those spots just to make sure we don't feel any lifts, heaves, or pulsatile pulsations that should not be there. So I'm going to go ahead and touch your chest, okay?
Okay.
Feeling for any lifts, heaves, or any pulsatiles or pulsations that should not be there. The next thing we're going to do is going to listen in all 5 of our areas. First, listening to the aortic area at the second intercostal space on the right side. Perfect. Next, we're listening to our pulmonic area. And all this listening is being done with the diaphragm right now. Next, we're going to go on to Erb's point. Next, we're going to go in the tricuspid area. And in the mitral area. We're going to listen again with the bell of our stethoscope in all 5 areas. First, listening at the aortic area. Next, listening in the pulmonic area. Next, listening in Erb's point. Listening in the tricuspid area. And listening in the mitral area. So perfect. The patient had all normal heart sounds. S1 and S2 were normal and appropriate. You didn't hear any S3 or S4 or any split S1 or S2. Yeah. So next we're going to auscultate for any bruits, starting with the carotid arteries and then our abdominal aortic arteries, the renal arteries, the iliac arteries, and the femoral arteries. This auscultation is going to be done with the bell. So I'm going to have you go ahead and hold your breath for this one. Okay, perfect. Perfect. Can go ahead and breathe normally. So those were no femoral bruits. Next, we're going to listen at the epigastric area for the aortic bruits, which we don't hear any. Next, we're going to move down to the renal arteries. Try to a little bit harder to listen to. Perfect. Next, we're going to move down to the iliac arteries. And lastly, we're going to listen to the femoral arteries. Perfect. With listening to the bell of the stethoscope on the arteries, the patient did not have any bruise, excuse me. Next, we're going to assess the pulses of the patient. We're going to assess the radial arteries, or I'm going to talk. We're going to assess the radial arteries and the femoral arteries on the patient. Then we're going to slide down to the popliteal arteries, the posterior tibialis, and the dorsalis pedis. So first, I'm going to slide my 2 fingers and check the femoral, or excuse me, the carotid arteries. Perfect. Next, I'm going to check the radial arteries. Perfect. I'm going to touch your groin, okay? Next, I'm going to check the femoral arteries. Okay. I'm going to have you uncross your legs for me. I'm going to have you bend this leg. I'm going to position my thumbs right on your knee, and I'm going to reach back behind the knee and check your popliteal artery. I'm going to do the same thing with the other leg. Encircling the leg with my thumbs on her knee, I'm going to check for the popliteal artery. Perfect. I'm going to check that. Perfect. And I'm going to check the dorsalis pedis arteries, the pedal pulses. Perfect. All of our arteries were intact. Arteries or pulses are graded on a scale from 0 to 3, 0 being absent, 1 being diminished, 2 being normal, and 3 being abounding. The patient had all +2 pulses in all of the arteries that we checked. And when we were inspecting the lower extremities for the pulses, we inspected for any types of edema, any pitting edema, dependent edema, or anasarca edema, which the patient is negative for. Her skin was pink, warm, dry, and intact. And go ahead and sit up for me real quick. Perfect. Now I'm just going to check your skin turgor real quick, okay? Perfect. No tinting. Patient's skin is well hydrated with good capillary refill, okay? Moving on. All right, moving on to our abdominal assessment. You can lay back down. Thank you. So first thing that we're going to do for the abdominal assessment is that we're going to inspect the abdomen, making sure that we are free of any scars, lesions, any masses or striata, no dilated veins, no pulsatile or pulsations visible, which could indicate that there might be a possible AAA, and that area should not be palpated whatsoever, with risk of rupturing that into the abdomen and the patient bleeding out. So looking at our patient's abdomen, they are free from any abnormalities that we can see. No scars, no masses, no pulsatile vibrations or that were visible. So the next thing that we're going to do is auscultate. We're going to start in the right lower quadrant, moving around in the normal way our bowels move. We're going to listen to each quadrant If we would listen for 1 minute in each quadrant. If we did not hear anything, we'd listen for 5 minutes to make sure that we were differentiating between hypoactive vowel sounds and absent vowel sounds. So the first thing that we're going to do is listen. Perfect. And the patient had very normal active vowel sounds with no friction rubs or venous hums. Um, a friction rub could indicate or would be represented as a grating sound while you're listening. It could indicate the presence of inflammation um, or a liver tumor, chlamydia, gonorrhea. While a friction rub would be heard mostly over the liver area, the aspect, which could indicate a hepatic carcinoma. Um, since we've ruled out the venous hum and the friction rub, the next thing that we're going to do is we're going to percuss. So let me grab my hammer. Okay. I got our reflex hammer. Again, for percussion, you're going to use the third digit of your non-dominant hand, and you can place it on the patient's abdomen and do a gentle tap with a reflex hammer, or sometimes you can even use your own second and third digit to help percuss the abdomen. Again, you're going to start in the right lower quadrant, moving around in the normal direction that the bowels normally move. So we're going to percuss. Okay. So there were no hyper resonance, which could indicate trapped air or anything like that. So the next thing that we want to do is we are going to check on the liver. So we're going to percuss in the right upper quadrant, moving towards the liver, and we're going to measure a normal liver is anywhere from 6 to 12 centimeters, so that's hoping where we'll fall. And you'll be able to find the liver as you move into the more dull sounding areas because the liver is a solid structure. Perfect. Now we're just going to measure. That's about 8.5 centimeters. So the patient's liver is within the normal range. If it wasn't, or if it was over the normal range, it could indicate a hepatomegaly. So the next thing that we're going to do is palpate. We're going to start with light palpation, starting in the right lower quadrant and working along the normal colon path, and then we're going to get into some deeper palpation right after that light palpation. Tell me if you have any pain or tenderness, okay?
Okay.
Any pain or tenderness?
No.
Okay, next we're going to move to deep palpation. Any pain or tenderness when I was doing any of that? So the patient's non-tender to light or deep palpation when following along that colon path. So she doesn't have any tenderness. So the next thing that we'd want to rule out would be cholecystitis. For that, we'd use the Murphy's test. For that, I'm going to have our patient to now increase or inhale, and I'm going to palpate deep in the upper right-hand quadrant to see if I can feel any hepatomegaly or any enlargement in the spleen or liver, excuse me. So go ahead, a nice big inhale. Sorry, I'm going to go a little bit deep in there. Any pain when I'm doing any of that?
No.
Okay. So if the patient did have pain or tenderness when performing that Murphy's sign, that might be indicative of some cholecystitis uh, that is going on. Moving on to the tests for appendicitis, let me grab. All right, so we're going to now palpate for the appendicitis tests, or run the special test for the appendicitis. So the first test that we're going to do is called the psoas test. So I'm going to place my hands on your thigh. I'm going to have you kind of raise up your leg when your leg is extended. Any pain right there in the lower right quadrant?
No.
So that'd be a negative psoas test. The next test that we can run is that the obturator test. So we're going to slightly bend our knee. We're going to inward rotate of the hip. Do you have any pain on that right quadrant? No. Perfect. I'm going to do the same thing with this left leg. Slightly bend the hip and an internal rotation. Any pain in that right quadrant? No. Okay. So the next test that we're going to do is deeply palpate the Rossig sign. Deeply palpate that right lower quadrant and then quickly release. If she had pain there, it might be indicative of appendicitis. Do you have any pain when I let go? Perfect. So now checking for rebound tenderness, we're going to check that lower left quadrant, and we're going to do the same stuff. We're going to palpate and then release, and if she had any referred pain over to that right lower quadrant, that might be indicative of appendicitis. Do you have any pain when I'm doing that? Perfect. So the patient did not have any pain with those deep palpations, so we wouldn't be worried about appendicitis for those tests. So now we're going to move on to the neurological exam. So to check the neurological component of the head to toe, first I'm going to have you go ahead and sit up for me. And don't go too fast, I don't want you to get dizzy. So I'm going to have you go ahead and walk towards the camera. I know it's not much that you can do, but go ahead and just try to briefly walk. And then back. Perfect. So go ahead and have a seat. The patient was able to walk without any swaying, unsteadiness. So the patient had a smooth and steady gait. There was no steppage, step off, or anything like that. So the next thing I'm going to have you do is I'm going to have you stand for me. We're going to do what's called a Romberg test. So I'm going to have you close your eyes and then keep standing for 1 minute. If the patient had any neurological dysfunction, they would have major sway in their stance as they sat there with their eyes closed. Yeah. And you'd be able to tell they wouldn't have a very steady balance with their proprioception. So you can go ahead and have a seat for me. Thank you. The next thing that we're going to check is the finger to thumb test, or the point test. So I'm going to have you touch your nose with one of your hands and then my finger. Perfect. And then keep doing that. Perfect. And then we're going to switch hands. Perfect. Good job. So she did the finger to nose, or the point test, really easy. So the next thing I'm going to have you do is on both hands, I'm going to have you touch your thumb to each finger. Just checking those coordination and making sure you don't have any neurological deficits. Patient's able to accurately perform a finger to thumb test on both hands without any difficulty in the coordination and her movements. So her neurological aspect on the finger to thumb test is intact. Moving on, we're going to move on to the pronator drift test. So that's where you hold your arms out, both arms right in front of you. I'm going to have you close your eyes, and I don't want you to let your arms fall. So we would have our patient do this for about 10 seconds and to see if any pronator drift would happen. You can go ahead and open your eyes. I'm going to have you go ahead and keep your hands there. I should have had you done that first. I'm sorry. So first you want to establish a baseline for the pronator drift, which is having their arms out straight with their eyes open, and then have them shut their eyes for 10 seconds. If they have any type of neurological deficits, one arm might float to the floor while the other stays nice and steady. Next, we're going to move on to a sensory aspect of the neurological test. I have something sharp and something light. Or dull. I'm gonna have you tell me which one you feel with your eyes shut. Okay, that's gonna be the dull, and that's gonna be the sharp. Okay.
Okay.
All right.
Dull. Sharp. Sharp. Dull. Sharp. Dull. Sharp. Dull.
And now I'm gonna test your lower sensation.
Sharp. Dull. Sharp. Dull. Sharp. Dull.
Perfect. The patient is able to identify sharp versus dull sensation. So sensation is attacked for both upper and lower extremities. The next thing I'm going to have you do is go ahead and close your eyes. And I'm going to place a common item in your hand, and you should be able to accurately identify what it is.
Coin.
Perfect. And then what about this?
Paperclip.
Paperclip, that's right. So she's able to accurately identify both of those objects that I placed in her hand, so the stereogenesis is intact. Next, we're going to test the, I forgot how to say it. Graphesthesia. So the graphesthesia involves me having the patient close their eyes and draw a symbol on their hand, which they should be able to accurately trace in their mind's eye and identify. So go ahead and close your eyes for me.
Triangle.
Yes.
Circle.
Yes. Perfect. She was able to accurately identify and discriminate the sensations in the hand that I drew. So I'm going to have you go ahead and lay flat for me one more time. And so now we're going to test the meninges of the neurological component. So the first test that we're going to do is what's called a Rudinsky's test. So we're going to have you flex. Go ahead and uncross your feet. I'm going to have you flex your knee. And are you having any pain in your neck or back?
No.
Perfect. I'm going to have you do the same thing over here. Any pain in your back?
No.
Or neck?
No.
Perfect. So the patient didn't have any pain in her neck with the flexion of the hips and the knees. So that's a negative Rudinsky's test. So the next test that we're going to move on to is the Koenig's test, which is you're able to do that yourself. Go ahead and tuck your chin to your chest for me. And are you having any pain in the spine or neck? Nope. So the patient is not having any pain in the neck or spine, so that's a negative Koenig's sign. And with that, that concludes the end of the head to toe exam. Thank you so much, Danny, for being present.